Atrial fibrillation is the most common heart arrhythmia, affecting approximately 2 million Americans. On this week's Health Talk, we're going to discuss treatments for this condition, including a promising new state-of-the-art procedure. Stay tuned, we're up next. Hello, I'm Dr. Eric Baser. Today we're going to talk about atrial fibrillation, or AFib. Joining me in the first segment are Dr. Murali Chiravuri and Dr. Eugene Fernandes, cardiac electrophysiologist and cardiac surgeon. Welcome both to Health Talk. Welcome back. I know you've both been here before.
Thank you.
So we've got both a cardiac surgeon coming to talk about atrial fibrillation. That shows you the changes in the way we've thought about it. But let's talk about atrial fibrillation. I think everybody is familiar with it at home because of all the advertisements for AFib. Right. But I suspect, although people have heard about it, they don't really know what it is. So maybe we start with you, Maury.
Sure. That's a great point. It's an extraordinarily common arrhythmia. It's the most common arrhythmia we see nowadays. And as you mentioned, as millions of Americans are diagnosed with it, and in fact, it's interesting to note that the projections are that the prevalence is going to double within the next 3 to 4 decades.
Is that because we're getting older?
It's multifactorial. I think, number one, the prevalence itself is increasing. We're living longer with multiple comorbidities. But also because I think we're more sensitive. We're picking it up, whereas years ago we wouldn't have known that people had this irregular heartbeat.
And we also are having an awful lot more people with heart disease surviving their heart disease.
And not just heart disease, other kinds of conditions as well. But coming back to your point about what is atrial fibrillation, just take a step back in terms of what's normal heart function. Normally, your heart beats in a sequential manner. You have the biological pacemaker, which then spreads its signals to the atrium and then the ventricle. Atrial fibrillation is a rhythm where the atrium, the upper chamber of the heart, is not beating in a coordinated fashion, but it's fibrillating. And so the heart is beating in an erratic or irregular way. In fact, it's that irregularity that characterizes atrial fibrillation.
And maybe we could point out that atrial fibrillation, the atria is, as you said, the upper chamber. The ventricular fibrillation is fatal. So right. Maybe differentiate between those two, because people, I think, may have heard of ventricular fibrillation.
Ventricular fibrillation, the heart cannot eject as a pump. So what happens is that the heart just fibrillates and does not empty itself. So the patient effectively does not have any blood pressure, and the heart, what we call, comes to a standstill. In atrial fibrillation, on the other hand, the atria cannot empty properly, but they empty to a certain extent. And the cardiac output and the blood pressure are well maintained, so the patient feels palpitations or lightheadedness, but does not suffer a cardiac arrest.
You know, I've heard the atria that is fibrillating described as a bag of worms, that it sort of wiggles around, but it's not giving that coordinated pump, which gives that extra boost into the ventricle so it can pump blood to the body. So you said some people are symptomatic, some people have those. What are the problems and some of the side effects of having, or the symptoms of having atrial fibrillation?
So atrial fibrillation, again, there are millions of people who have it, and it can present in many different ways. Some of the common symptoms people can have are palpitations. They can have shortness of breath with exertion.
So they lose that normal pacemaker, don't they?
That's correct. They're lacking the synchrony of the upper and lower chambers of the heart. And some people just feel a generalized malaise. But there are some people with atrial fibrillation who don't even feel it and don't know that they're in the arrhythmia as well.
Which is really interesting that some people, again, are so conscious of these palpitations and others can go on without it. And there are also problems with blood clotting if you have atrial fibrillation. Maybe you could say a few words about that.
Because the atria don't empty, blood tends to stagnate in parts of the atria, like the appendage of the atrium. And since it does not move and just remains stagnant there, it tends to clot.
You know, a lot of people don't realize, I'm a hematologist, that simply keeping the blood moving is important to keep it from clotting. And so if it stagnates somewhere in a pool, even if it's in the appendage of the atrium or somewhere else in the body in an aneurysm, it can actually clot there. And once you form a clot, you run the risk of stroke, an embolism.
Absolutely. And I think that's a critical point, which is, as Dr. Fernandes mentioned, atrial fibrillation is not a lethal arrhythmia like ventricular fibrillation, but your risk of a stroke goes up 5-fold if you have atrial fibrillation. And In fact, there's about 800,000 strokes a year in the United States, and a very significant fraction of those are due to atrial fibrillation.
Yeah, as we control other risk factors, I would think that those are actually increasing.
Absolutely.
Now, we treat atrial fibrillation. Before we talk about treating the electrical disturbance, maybe we could talk a little bit about treating the clots, because that's changed a lot, and that's led to all the television commercials. Gene, maybe say a couple of words about that.
Historically, the patient would if the patient was in atrial fibrillation for more than 48 hours, he would be put first on heparin and then put on Coumadin, which was the traditional way of anticoagulating.
Which is sort of the standard old-fashioned blood thinner.
Right. But the problem with Coumadin is that you need to have your blood tested twice a week or once a week, and you have to be very strict with diets. With the new anticoagulating drugs now, the efficacy is pretty good, and you don't have to do your blood tests every week, and your diet need not be that stringent. So it's more patient-friendly with as much efficacy as the traditional Coumadin.
Yeah, and there are at least 4 of these, I should say. There are 4 of these new or novel oral anticoagulant drugs available now.
But you bring up a great point, which is, gosh, times have changed. So Coumadin, warfarin was approved by the FDA in 1953. And that was the only choice we had until 2010.
Coumadin, we should point out, was rat poison.
Yes, it was a rodenticide. In fact, the original name is warfarin, which is the Wisconsin Alumni Research Foundation. But it's a very nonspecific agent. You take a pill every day, but we don't know what your serum concentration is, which is why we obviously have to check your levels. But there are 4 new anticoagulants now. And in order of FDA approval, starting in 2010, there's dabigatran, Pradaxa, Xarelto, or rivaroxaban, Eliquis, which is apixaban, and then the final one, Tyvaso or edoxaban. And these agents, I think, have revolutionized how we treat patients with atrial fibrillation, because you take a pill every day. We don't have to check levels. It's got predictable pharmacodynamics. And I think it's critically important that if you meet certain risk criteria, that taking an anticoagulant, a blood thinner, is mandatory for people who have atrial fibrillation, because nothing's going to change one's life like a stroke.
Yeah. And I think you made the point. We've also had a lot of experience with atrial fibrillation now, so that we are able to risk stratify patients. And there are a small subset of patients who have a very low risk. I don't know whether you want to talk about the I'm blanking on the
lone AFib.
Yeah, the
CHADS,
scoring.
the
CHADS-VASc2 score.
Sure.
But we were able to score people fairly simply.
Absolutely. And in fact, I think your point's well taken, which is if somebody has no concomitant clinical risk factors, they actually don't need to be on a blood thinner necessarily.
And we know that because their risk of stroke is so low.
Is very low. But if you have certain criteria, and just very quickly, these would include congestive heart failure, hypertension, and age over 65, and in particular 75 years old, diabetes, a previous history of a stroke or a TIA, or any vascular disease, and a female sex, these all confer additional and cumulative risk onto the patient.
And as far as I know, there's no data favoring one of the new novel oral anticoagulants over the other. Is that true, or do you have your favorites?
There are some differences. So when it comes to the new novel oral anticoagulants, the first one which was approved was Pradaxa, or dabigatran, which is actually a direct thrombin inhibitor, whereas all the subsequent ones are factor Xa inhibitors.
So these are a little bit different mechanism of action.
Slightly different mechanism, but if you look at, by and large, I think that every one of these new direct or novel oral anticoagulants is a significant improvement over warfarin. Wouldn't you agree, Eugene?
Right. I think, and it's very effective, as well as the patients like it,
Yeah.
So
and for a while, I think there was some concern about the fact that we didn't have reversal agents for these, but that's pretty much been taken care of. We now have specific reversal. Plus, they get out of the system faster than warfarin, so that we may not have to reverse them.
That's a great point. And in fact, there's some studies which actually show that the mortality after you have a bleed on warfarin or Coumadin is still higher than it is for these direct oral anticoagulants. But having said that, antidotes have been developed for these. One of them has been approved by the FDA for Pradaxa, and in my opinion, there's another one that's coming out.
Just tested and worked.
Tested and worked and been published, so I do think it's a matter of time before the FDA approves those as well.
Yeah, as a hematologist, the other thing, and I don't want to get too much into the weeds, but the direct-acting anticoagulants, which actually impair blood clotting, would make sense to be more effective than one that than warfarin that simply lowers the concentrations of blood clotting factors.
That's right.
Yes.
I sort of liken that when I'm teaching students to if there's a forest fire going, you have to take a big hose and put out the fire. You don't go in and clear out the brush and hope that the fire's going to go away. So I think that these direct-acting ones offer lots of benefits, except for cost, obviously.
A big problem.
But they make so much sense, and they really have revolutionized our approach to these folks.
Absolutely.
And made their lives a lot better. But in addition to preventing clot in somebody who's got atrial fibrillations, sometimes you decide to change the rhythm, try to get them back in what we call normal sinus rhythm. The rhythm induced by atrial fibrillation is very chaotic. It's sort of random electrical impulses to get to the ventricle and cause it to contract. So if you say a few words about how you decide to try to control rhythm versus just keeping them at an acceptable rate. In fact, that's the big controversy always. I should say controversy. Decision, rate versus rhythm. How do you decide? Let's start with
Sure. So when you have a patient who's diagnosed with atrial fibrillation, there are a few key points to take into account. The first of those is the patient symptomatic? Do they feel poorly when they're in atrial fibrillation? Number two, is it causing any detriment to them? Is it, for example, impairing their exertional activity? Is it causing their heart to fail? Are their rates completely out of control? If it turns out they don't feel a thing, they're completely asymptomatic, even with exertion, their rates are well controlled, and they're on a blood thinner if they need to be, quite honestly, leaving them in atrial fibrillation is not unreasonable. The problem lies when most people have a lot of symptoms.
You ever have patients who say, I'm just uncomfortable having my heart
Absolutely.
fibrillated and I'd rather be in normal sinus? Because I know that's the way I would feel based on nothing, just other than the...
But you know, in my opinion, people know their bodies better than anybody else. And very often that is code for, I'm not feeling right, something is wrong. And when those patients come in and they're feeling symptomatic, or their rates are very difficult to control, or their heart function has diminished, and Dr. Fernandes and I have seen many of these people, those are people where it's actually much more reasonable, perhaps, to put them back in normal rhythm.
Right. Is there any, if someone, the ideal candidate for leaving them in atrial fibrillation, is there any disadvantage of doing that in terms of their long-term outcome? Will they eventually develop some other problems with their heart?
There is a problem. And the problem, and I think I'll let Dr. Fernandes address this too, is the longer you wait, the more their heart gets used to atrial fibrillation. The same therapies may not be as effective. Do you agree?
Right. And as the longer they are in atrial fibrillation, the bigger the chambers or upper chambers of the heart become. And they become thicker and bigger, and then the atrial fibrillation becomes very resistant to control.
And so you may need the kick when you're 80 years old, but you don't need it at 60. Right. But it'd be harder to get it back into giving you the kick at
because
80.
The same therapies would be less effective after you've let the person be in AFib for so many years.
So this is an ongoing discussion. If you leave somebody in AFib, you may do that for this year, but 2 years from now you may say, well, maybe now's the time that we should reconsider.
Or forever hold your peace, because you know, it's going to be harder for us to control this 5 years from now or 10 years from now.
And I think with chronic atrial fibrillation, as the chambers become bigger, the valves start leaking also. You get, you know, we see a lot of patients with chronic AFib who have their valves leaking just because the heart has become so big.
And that can cause further, so it's not a benign condition to leave it like that.
Correct. And there are some people who, quite honestly, their heart function starts to diminish because they're in atrial fibrillation. And together, we've seen many of these patients, and remarkably, we treat those patients very aggressively. We want them back in normal rhythm. And when we do that, we're able to, you know, reverse a significant portion of the dilatation and the remodeling of the heart.
And the ejection fraction improves within a few
well
days,
the heart
if not a
is
week.
Yeah. Well, gee, you know, that's a perfect segue. We're going to come back in the second segment and talk a little bit about the ways we can take someone from atrial fibrillation and put them back in normal sinus rhythm, and some of the approaches that we have, which are really novel and fabulous. But we're going to take a short break. Hi, we're back with our guest, Dr. Murali pronounce your last name for me.
Chiravuri.
And Dr. Eugene Fernandes, cardiac surgeon, electrophysiologist. So we just, as we left, we were talking about atrial fibrillation and bringing somebody back into normal rhythm. And what is the first approach used, or what are some of the considerations? I think I'm pointing at Murali because he's the electrophysiologist.
Correct.
He usually sees them in that setting, and then when we get to the surgical approaches, we'll move over here.
Sure. So when we see a person who comes in and happens to be in atrial fibrillation, the first question is related to what we were saying earlier, which is, are they symptomatic? Do they have any left ventricular dysfunction? Are their rates poorly controlled? If any of those conditions are met, obviously we want to try and put them back in normal rhythm. And we have many ways to do that. And one of the first approaches we often will try are medications. Rate control medications, medications that you take that make it hard for you to go back into atrial fibrillation. Very often, even if we give them medications, we still have to do what's called a cardioversion, where we basically put a couple of pads on them and just give them a little electric shock.
Yeah. It's very much like rebooting a computer.
It is.
Not to be too simple, but you're literally pulling the plug by shocking it and making it start again.
Takes a grand total of 10 seconds, resets the heart, and then we watch them on the medications to see if that holds them.
And by the way, we should say this is different than somebody who is in cardiac arrest and you're shocking.
Absolutely.
This is an elective cardioversion, and it's
Exactly.
lower voltage.
Elective, lower risk, extraordinarily well tolerated. And once we do that, we see how they're doing. If they do have a recurrence of atrial fibrillation, that's when we start to say, hey, look, the medications alone are not keeping you in normal rhythm. That's when we have to consider something a little more invasive, if you will.
And this is where our understanding of the electrical flow in atrial fibrillation has really helped us change things. Again, I think since with the advent of EP and open heart mapping, we actually have some idea as to why the electrical impulses go so awry. Maybe you could say a few words about that. You know, what's happening with the electricity? Normally we have a pacemaker in what we call the sinus node that sort of ticks along and spreads the electrical impulses in an organized way. But what's going on in atrial fib?
Well, initially, when you get atrial fibrillation, the abnormal impulses come from the points where the veins from the lungs join the upper chamber of the heart, the left atrium. And as atrial fibrillation becomes chronic and the left atrium becomes bigger, those trigger zones start developing inside the body of the left atrium. So you cannot completely treat the chronic patient by just isolating the veins. You have to treat the body of the atrium.
So when it's coming from the veins, is it that they're not beating out at a proper thing, or that one vein is that you're getting multiple impulses? You know, why is having the pacemaker in that area create fibrillation?
I mean, that's a great point, but your pacemaker is literally being overpowered. Your pacemaker is beating like a metronome, but all of a sudden you have these pulmonary veins in the left atrium, which is where the blood empties from the lungs to the heart, like Dr. Fernandes was saying. But these are basically firing randomly and rapidly, 400 times a minute, just shooting out abnormal signals.
So there's really no controlled cycling.
It's just random. And here's the problem, which is, in the beginning, in early stages of atrial fibrillation, the entire problem is localized to those pulmonary veins, an easier target. But as they progress to a more persistent and chronic state, the veins themselves are no longer the only problem. The problem is now spread to the whole left atrium.
So you get random impulses coming from
different parts of the left atrium.
Exactly.
And the reason you get disorganized spread from the pulmonary veins, do they not have the proper electrical wiring into the atrium?
Quite honestly, there's too much wiring. So basically, the problem is that when these abnormal little sleeves of tissue in the pulmonary veins are firing rapidly and randomly, they're not contained. They're spreading through all the network of wires. What we accomplish is to electrically isolate those. We build a little dam around those pulmonary veins so those signals can't escape.
Destroying tissue.
Scar tissue.
Yes.
Creating scar tissue.
Okay,
how about delivering radio frequency? Yep. Right.
So, creating a block so those electrical signals. Yes, we want to make it. You're not destroying the heart of this.
No.
But you're creating a block using radio frequency or heat or something.
Absolutely. And in fact, there's no anatomic change to the heart. If somebody did an echocardiogram or an image of your heart after we're done with an ablation, they would have no idea we were there.
So in early atrial fib I mean, early, if you're going to do an electrophysiologic procedure, is that something you do, Murali, or is that
Yes.
is it where you do alone from the inside?
That is correct. So what we do is we do everything endovascularly, which means we actually go through the blood vessels of the heart, go to those pulmonary veins, and using a multitude of technologies, including radiofrequency, which is heating, or cryoablation, which is
cold.
Which is
Cold,
cold.
frozen.
Yeah, right. We basically create little lines of block around those pulmonary veins. And for those people who have very early paroxysmal atrial fibrillation, they're just going in and out of it, it's very effective.
And those areas of block, they ultimately scar into scar tissue?
Correct.
They do, and this scar is very small. It's linear, it's measured in millimeters, and that's the whole goal, is to prevent these abnormal signals from spreading. But as we were discussing, the problem sometimes lies when people who have been in AFib for a long time, it's now not so localized to those
So you
pulmonary
can't
veins.
just
You still need to do it. You still need to do it, but that's when we sort of work together to.
And we actually have a video of this, so maybe we can bring up the video and you can walk us through this, because it really talks about, you go from the outside of the heart, right?
So it's a convergent
here we
procedure.
are. Explain.
Or the hybrid procedure. The blue lines show the lesion. This is how I enter into the chest, through the belly, through the diaphragm, which is the muscle separating the heart and the belly.
Is that what it looks like to you as you're?
This is the device going to the back of the heart and creating the lesions on the back of the left atrium, which is the upper chamber of the heart.
So the electricity is flowing through the backside as well as the inside of the atrium.
Right.
The atrium is that, and the pulmonary veins, there's that light brownish structure.
Right, that's right.
And the heart is sitting on top.
Yeah, the device sticks to the heart by suction, and then the radiofrequency current is applied. So once the back wall is ablated, we isolate the pulmonary veins, first on the right side, here's showing the right side, then on the left side.
And it looks just like that when you're doing it, right?
Exactly.
It's color-coded for you as you go in. And,
Now at this point, my part of the procedure is over. The patient goes to the cath lab where Dr. Chiravuri
and Murali, this is you doing this now.
Correct.
He will pass a catheter through the right chamber of the heart, through the septum, through the left chamber, and do the mapping and testing from inside the heart, and complete the ablation if needed from inside.
After you do something like this, again, let me ask the same question. Do you lose myocardial tissue, or you see a little reduction in the ejection fraction of the atrium?
We don't actually, and what's very interesting is it's very often the opposite, which is once the parts that we're ablating actually are not often sites that are particularly involved in transport, particularly the back wall of the heart, which is a membranous structure. So quite honestly, putting them back into normal rhythm, what we often will see is an increase in the chamber's ability to transport blood and its actual function.
Now, you do all this on a beating heart?
Yes.
Yes.
Does the fibrillation stop as you're doing these
Very
blocks?
often.
It
Very
does, and if we're also able to sometimes organize it into other arrhythmias called flutters, and once we do that, we're able to sort of chase down where it's coming from and terminate the arrhythmia. We're able to do that in many of the cases. In some cases, we actually have to cardiovert them, but in a lot of the cases, we're able to break the arrhythmia.
Now, Gene, do you use mapping when you are on the outside of the heart as well?
The newer devices have come out with mapping.
So you get immediate feedback as to where the electrical current is going, and you know whether you're in the right place. Let me ask a layman's question. What keeps you from burning right through the heart, creating a hole by accident?
The device sucks onto the heart, and then you measure the impedance. It also measures the impedance. And it delivers the radiofrequency current for about 90 seconds based on an algorithm which is predetermined by computerized models.
So once more, the computers are really giving us a very sophisticated approach.
And just, especially when we're going in from the inside, we use there's a lot of indices that we're using to guide us. We not only measure impedances, as Dr. Fernandes mentioned, but we're also we actually have pressure sensors on our catheters. We're measuring temperatures. They have thermistors. They're irrigated. We have echocardiographic visualization, fluoroscopic visualization. So there's a lot of different tools that are quite additive, actually.
So you're pretty confident as you're doing these things that you're not jamming a hole through the heart.
The risk of this procedure is less than 1%.
Correct, and that's a cumulative risk.
Yeah, and the patient goes home in 3 days with very little disturbance to his normal routine.
We should point out that even though you restore a normal rhythm, the electrical signal looks normal, it takes a while for the atrium to begin to pump normally, doesn't it?
Absolutely. In fact, there's a lot of good data for this, which is when you cardiovert somebody, they've been in atrial fibrillation for a period of time, and you cardiovert them, their atrium gets a little stunned when it gets back to normal. In about 4 weeks, it's back not only to normal, but better than it was in atrial fibrillation. But in the first few weeks after putting them back in normal rhythm, function actually goes down.
So we're back on anticoagulants for at least that period of time.
In fact, 90 days.
90 days.
We've run out of time, but what's the success if you decide to convert somebody using the electrophysiologic, using your approaches, what percentage of patients can you get back into sinus rhythm?
With the convergent technique, almost 80%.
And don't forget, that's patients who have persistent and more chronic atrial fibrillation. The catheter-based ablations alone for paroxysmals is about 85%. But that's atrial fibrillation that's more early and easier and more malleable.
So we're really getting up there with the vast majority, not everybody, the vast majority.
And even those remnants, the 20% of people who are going back into atrial fibrillation, we very often find that they're easier to control than patients who didn't have the procedure.
Which makes a lot of sense. That's all we have time for. I'm going to ask you to stay around for the question, but thank you so much.
Thank you.
Really interesting topic. When we come back, we will answer today's health question, but right now, let's take a look at some of the upcoming events sponsored by the Western Connecticut Health Network. Hi, our question for this week is, what is valvular heart disease? We have two experts who deal with the heart valves all the time. Valvular heart disease is a big part of your job, isn't it?
A lot of the surgery we perform is for valvular heart disease. There are two major valves that are commonly affected. One is the aortic valve, which can be either malformed since birth, which we call congenital bicuspid aortic valve. And the second type of problem that affects the aortic valve is what we call senile or degenerative aortic valve disease, where because of senility the valve gets first stiff and then gets calcified. The second valve that gets involved most commonly is the mitral valve, and that is either because of cardiomyopathies or ischemia or rheumatic fever, which we very rarely see today. And the mitral valve can be affected either by becoming narrow, which we call mitral stenosis, or it can start leaking, which we call mitral regurgitation. In today's practice, I would say 80% or more is from a leaking valve. And the most probably the most common cause is because either the valve starts leaking because of it starts prolapsing from high blood pressure and changes in the ventricular dynamics, or from previous heart attacks.
And that's the answer. That's all we have time for. Thank you so much. And that's becoming a big part of your business now, I know, that the valve, and some fabulous things about the valves. So if you're at home and you have a question you want to ask on Health Talk, please contact us at HealthTalk@norwalkhealth.org. I want to thank our guests, Dr. Eugene Fernandes, cardiothoracic surgeon, and Dr. Murali Chiravuri, cardiologist and electrophysiologist, for coming on our show and talking to us about atrial fibrillation. I'll see you next week on Health Talk.